have SI6. Come on in.
Come on, you guys.
You guys got the tools? Oh, look at that.
That's great.
All right.
Hello.
So here we are getting all set up. So this is SIFix. It's an SI Joint Fusion. We're going to be going over it with Dr. Jose Medina Sanchez. Thanks for joining us.
Oh, absolutely. I'm excited.
You're coming from sunny Florida as well.
From sunny Florida, yeah.
Yeah, so they got two of us out here.
That's
That's
what we do.
That's what we do. I tell people it's the best state to live in, but we'll leave every now and then. We'll leave every now and then to come visit you guys.
No, my pleasure. Thank you for having us.
Thank you very much. And then introduce yourself.
Cody Schwartz with SIFix out of Miami, Florida.
Awesome. So he's my rep down in Florida. Your rep as well, right?
Our rep over there in Tampa as well, yes.
Perfect. So let's get started. I think we can start with the slides if you'd like.
Okay.
I can move forward if you want. Oh, that's the same thing. That's the laser pointer. Should be able to go forward.
So let's see. Okay.
We'll get it going.
So let's get it going.
There you go.
So as I said, my name is Dr. Medina Sanchez. So out of Tampa, Florida. Worked for Physician Partners of America for the past 5 years. Over there, here we go. Medical director of our Sun City Center's ambulatory surgical center. So basically, we're talking today about SIFix. SIFix, we have the sacroiliac joint, basically what connects the upper extremity lumbar spine to the rest of your body, the pelvis and your legs. So that absorbs a lot of pressure, obviously. So typically, a lot of patients have a lot of pain there post fusion, especially on the lower levels, L4-5, L5-S1, given that when they're fused, obviously that area, that segment is not moving. So typically, all the range of motion is absorbed by the upper segments and the lower segments. So the SI joint really goes into hypermobility, and the hypermobility, that constant irritation and extra movement will create the irritation that will cause the pain. So here we have those areas. There we go. So that's fine. Yep. So basically, patient selection, always keeping them almost as a knee-jerk reflex. Whenever a patient says it hurts right here, those are the patients are the literally tell you exactly where it is. They point right at it.
You go press on it and they say, "Oh yeah, that's
they
it."
jump.
I mean, right in that spot.
Yeah,
so.
exactly. The chandelier, almost like a chandelier sign. They jump and grab the chandelier because of how much that it hurts.
Mm-hmm.
But literally, they point right at it. They point right at it. Have a high level of suspicion whenever a patient says, "Doc, it hurts whenever I sit down for too long, stand for too long." That little movement of getting right up there, that little last range of motion when you sit down and stand up, that's where it hurts the most. Typically, a lot of patients also have pain radiated to their hips. Mm-hmm. And then you do like a trochanteric hip injection and bursitis injection. They get better, but not really. And all of a sudden, the pain comes back. So again, another high suspicion for doing this procedure. So the rationale of this is fusing the area. So that hypermobility, we stop it. And this is an FDA-approved device that is my choice, the SIFix. To be able to fuse this joint.
So how do we get from that patient that has the pain in their SI joint that you see walking in your office to how do you come to the conclusion this is for sure a bad enough problem to go fuse them?
Absolutely. So we do what is called diagnostic SI blocks. So what we can do it bedside, but it's even better we do it under fluoro. Mm-hmm. Bedside, we use anatomical landmarks like the posterior superior iliac spine. We will palpate those and then literally ask the patient, now that you have localized medial of the posterior superior iliac spine, where does it hurt the most? You go a little bit higher, a little bit lower, and then once you find that tender spot, again, the patient will let you know, and that's if you do it bedside. But preferably that way you can document and have everything that it's clear under a live X-ray machine, under fluoroscopic imaging, do the block. And you're looking, what I always say, a significant amount of relief for a significant amount of time. Yep. Some patients, the block lasts 6 months. Some patients, the block lasts 2 weeks. But if you actually block the pain generator, you're going to get relief. So that's what we're looking for in regards to diagnosing these symptoms.
Perfect. And I think one point you brought up that's very important is a lot of these patients do get that bursitis. Mm-hmm. And it's more of a secondary because they start walking different. They start moving different because of the SI joint. So patients come in, I have bursitis. And you do the bursitis injection.
Yes.
And it helps. But then it's going to come back because you haven't fixed the actual problem.
You haven't actually, exactly.
And a lot of what we're doing today is fixing the problem.
Fixing the issue.
blocking it.
Not just blocking. Having one thing doesn't make you immune to have other things. The main issue is the SI dysfunction that you are compensating, and then the hip motion will be altered, and that's where your bursitis come. Perfect. And you can have two things. You can have the bursitis and the SI. So yes.
So where in your algorithm are you, if you confirm, so we confirm they have SI joint disease clinically and Meyer block, and now you're going, okay, should I fuse them? Should I stem them? Should I burn them? How do you decide for which patient you're going to fuse? That's what I'm curious about.
Excellent question. Excellent question. Depending, first of all, age range. I would be very wary of fusing a lady with under childbearing years. Obviously, it may cause a dystocia when they're in labor. Something that if you do it for some reason, if the OBGYN is okay, then that's something that they have to know if for some reason that lady goes into labor. Also, the age. Patients sometimes they don't feel comfortable. Some of them with a device, and then we may do a stem. Personally, in the radiofrequency ablation of the SI joint, I've had very limited success. In when they finally decide to go into the SI joint fusion, is because they know that it's a fix. It's actually eliminating the source of pain. The other ones are just putting a nice little fancy band-aid. Okay, this one actually fixes it.
And I think even with the ablation, I mean, there's two issues with the ablation. For me, I do the ablation sometimes, see if the patient gets some good relief. Yeah. Is the nerves go back? Yeah. And also, you're not de-innervating the whole SI joint. I think people don't realize there's the superior cluneal coming over the top. There's the anterior nerves. So you're really just ablating the posterior nerves. If that works for the patient and gives them enough relief, great. But I think most of our ablation patients end up somewhere along the fusion line.
And that hypermobility stays there.
Yeah, that's
You're just blocking the nerve. You're just killing the messenger, basically.
Exactly. Good. Okay. Back to our regular scheduled program.
Excellent. All right, very good. So basically what I do first, if you can lift a little bit higher here, the fluoro. So we start with our anatomical landmarks. The posterior superior iliac spines are basically the most palpable structures that we can find. And like I always say, you can never, to start this procedure, you can never go too medial, too cephalad. You will always, if you do that, you will always be able to get underneath that posterior superior iliac spine to be able to get to the joint at the proper angle, which I will teach you. Because if you think about it, if you go too lateral, then you got to hop over that thing and get underneath. And if you go to caudal, the same way around, you have to basically somehow give it a turn. So typically I start around the transverse process of a L5 on the ipsilateral side. So here I would say picture.
You can do it on your own if you want.
Excellent, perfect. All right, perfect. So the trick to this, and you can never go wrong with it, unless obviously all anatomy changes, but typically 95% of the time, the opposite corner of the guide wire typically points to the contralateral corner of the room. So if you keep that in mind, it makes perfect sense, because if you see the SI joint goes like this, so you cannot. Some doctors will instinctively look at a fluoro and kind of like see the joint on a two-dimensional way. So we'll go at a 90 degree. That will never work. Look what happens if I go 90 degree. That thing is not going to go through. And then you're going to have to mallet a lot of that, and it will be resisting too much. But you have once you hit that angle to the opposite corner of the room, that's when it's going to slip in. And this should go in nicely. Like I said, if you're forcing it too much, you may want to take different views. So the views that we typically do is what is called the inlet view, which will keep it safe. So let's oblique a little bit more towards the.
What part of the SI joint are you hoping to land on?
Typically, I want to be lateral of the S1, S2 foramens. Okay. So I typically stay on that upper side. Okay. I don't want to be too low on it. Yes.
Question? Yeah.
No. All right. So basically on floor. So here, if you would move the fluoroscope a little bit towards me, I want to show you a very important point. Here, you notice the guide wire. If I keep going, I eventually get to the hip. That is the angle that you want, because once you start malleting this, you don't want to be too steep, because you want to stay away from obviously anterior of the sacrum. You don't want to go into the bladder and all those organs. So that's the safest. And it's funny because when you're in the OR and you know you're safe, and if you melt a little bit too hard and you get a lateral, you see that thing going anterior, and everybody gasps in the room except you because you know you're just going towards the hip.
You're staying lateral.
You're staying lateral.
You're safe.
So you just say, you know what? I'm the one doing the thing.
Not a malpractice insurance.
Exactly.
That's all your insurance.
So once that the guide wire is settled, now you have your first dilator. And the first dilator, again, should go nice and smooth. It should land right up the crest of that SI joint.
And I want to point out one thing while he's doing this. You might see him looking at the Biotross model. This is the great thing about this when we're teaching is you can see right where you're going.
Yes.
Right into that joint. We see it on fluoro. You feel it. Everything's the same. So that's one reason these Biotrosses really do really well with these procedures when you're learning and when you're really going over them with other people.
I totally agree.
The distributors or the direct salespeople, they can just bring this in their car and go to any doctor's office that has a fluoroscope in their office, and there's your training zone.
Yeah.
You don't have to get a cadaver cleared for COVID, for serology, for nothing. And you'll notice, you know how after a lab where there's cadaver, it takes 15, 20 minutes this is, okay, next, move on. And so I think you're going to find that this is a valuable teaching tool for you guys.
That's perfect.
I agree. What I mentioned earlier, that angle of the joint and having the opposite end pointing to the other the corner of the room, the upper corner of the room. Here's when you visualize it and you understand what I mean. Sometimes that's a difficult concept. That's why I typically, when I'm teaching these courses, I bring out the model. In this case, you don't have to bring out the model.
That's perfect.
We had a you don't have to damage the model in regards to contaminating it. So this all by itself. We can do a bunch of steps at the same time simultaneously.
And you're taking the dilator down to the interact with the bone?
Yes. Can we take a lateral in here?
Yep.
Excellent. Yes, right at that crest on the top of the SI joint.
Okay.
Yeah, Dr. Medina, why don't you talk about as well how you can make that adjustment once we get in that lateral?
Yes.
How we can make that adjustment on the pin?
Absolutely.
If need be?
Absolutely, we certainly can. We always want to stay on the safe side, and that's why we take both the inlet view, which is coming in from a caudal aspect, versus the outlet view where we're coming in from a cephalad aspect.
Pure lateral.
True lateral?
Yes, a true lateral. Let's go all the way. Yeah.
Yeah, nice thing with no cadaver, don't have to worry about contaminating the C-arm or any of that.
Yes. That's
Very cool. Infections or deaths.
exactly. Very, very cool. Okay. So look at this minor adjustment here. Let me just tap in a little bit more of that guide wire. Picture. Okay, this is one of the examples that I was saying. If I'm too aggressive with this, that's where everybody in the room gasps. If I go anterior, but we already took that safety view, knowing that we're staying away. We're going completely lateral. So the second dilator, you can notice that it's right at the crest. That's good enough. You may want to tap it a little bit more, but yep. And you see the level that I explained earlier, where in regards to we're lateral to that S1, S2 foramen. We want to stay on that upper level of the SI joint. If need to be, you may need the grasper if you want to get a little bit more, those dilators a little bit closer to the bone. So in this case, we have the grasper. There's for the first dilator and for the second dilator. The second dilator is
We took Chad's weights from his house. But that's the biggest one.
Mine would actually be a lot bigger than that.
The 2-pound weights.
So we tap it a little bit. Just to make sure picture. So see now that definitely you see that you don't have that halo underneath the second dilator. It's pressed against bone. So now it's time to use the claw here. So originally the claw.
That's the name for everything.
Yes, actually.
The drill guy.
The drill guy. We have sometimes when I'm doing all the procedures, I call give me the Rottweiler over there. Yeah.
They know what the hand is.
Exactly. I'm nothing without my team because they know what a Rottweiler is. So basically, the important thing about the claw here is that when you're doing the incision, when you're going to start, it is literally this length. And you don't have to go any more than that. That's the incision you want to do with your scalpel, and it will so that the first, second dilator and the claw will go right through.
So how big is your incision going to be overall?
This is like 4 millimeters.
4 millimeters.
Similar to that.
Pretty small incision.
It's a very small incision. Yes. And suturing, typical 3-layer ethibond on the bottom, maybe a bicryl, monocryl on top. It's
5 minutes.
5 minutes.
Like I was saying with spinal simplicity too, we need to start teaching suturing, in the fellowships and going through.
So picture.
What we're doing.
Yep.
So see how though the claw, you see that is completely. You can see both. Like the last thing that you want to do is this picture.
Yeah, show
See, now
rotated
basically
or-
rotate.
Yeah.
Now you don't see anything.
You probably can go live there and show. There you go.
Yeah.
Yep.
There you go. See, this you don't want that.
You don't want that.
You don't
Yep.
want that. You want those tiny claws to open that joint up. That is the reason why it's designed the way it is. That's why I like this product so much, because it opens up that joint as you mallet it in.
So it's distracting the
It's
joint.
distracting the joint, no doubt about it. Okay. So if that happens, this is very important. This device has these markers. So you want that marker correlates with the where the claws are. So that way, as you are malleting, you know that you don't want to be like this. You want to distract the joint to open it up. The way that it's designed, it's just like that. The more you mallet it in, the more it opens up.
And you get a pretty good tactile feel when it drops.
Yes, absolutely. And the real thing, that's why I like to start the way I do, cephalad and medial. That way I'm constantly asking for picture as I'm walking off the bone, and you feel that give.
Drop in.
When you feel that give, and it doesn't quite, it stays there. You know that it's solid. That's a good tactile feel. The more you do it, obviously, the better you get. But that's a good tactile feel that you're in the joint itself. So how much do you want to mallet that? Typically, I want to mallet that at a little bit more the anterior edge of that SI joint picture. Around that's a little bit more. Perfect. All right, so that's good.
Very nice.
All right, so we take this out. Typically here, let's go ahead. Before I drill, I want to take my safety shots prior. So let's go back to the AP and let's have that inlet view, which is oblique towards coming in caudally. Yes.
How do you like that?
I like here. Yes. Basically, what we want to see is right in the joint. Let's have it the other way. Let's do the outlet view coming in. Okay. So we have here. We're going to continue to distract that joint, and we just in this case we will mallet just a little bit more to make it in there.
Can you guys all, with your Invertex, see that? We're just a little bit too medial. Just a tad more. He should be in
Just
this.
exactly a little bit more lateral would be ideal, but no, that's fine.
No, we're good.
That's fine. We're good.
Just
And now I can. This is the time to do the drilling. I always drill lateral for obvious reasons to make sure that you're not too deep. Let's go pure lateral.
drill in lateral position, right?
Yes, always drill lateral and live. I like to drill live.
Go lateral.
Yes, please.
So it's a posterior approach versus a lateral approach. And so tell us about complications.
Complications, this minimal, like just like anything that pierces your skin, you have the risk of infection, excess bleeding. But other than that, in regards to tapping into vital structures or nerve damage, spinal cord nerve damage, basically zero, because we're completely away from the spinal cord canal. Spinal ends at L2. We are beyond that and lateral to that. So
no vasculature.
No vasculature. Obviously, precautions like no aspirin, anticoagulants, warfarin, Coumadin, Eliquis.
Surgery.
Exactly. Just regular surgical.
So now we drill.
Now it's drilling time. Yeah.
How fun is that? You can even drill.
Yeah. Live. So I always typically, personally, I've done it so much that I stay on my side and I pull towards me. Mm-hmm. If you have a bigger patient or you just don't feel comfortable yet, you can use gravity to your advantage and go to the opposite side and push down, and that'll be a little bit easier.
That's a good tip.
Yeah.
Yeah, and be careful. I like it this way. It gives me a little bit of control than more having gravity behind you, because sometimes I've had so much superiority women that when I go through the drill, that thing goes through like a hot knife through butter.
Yeah.
And you got to be very, very, very careful, because
Safety and control.
Absolutely.
Reliable outcomes.
So you go clockwise, pushing towards you. That thing is right. You feel the grind.
And you can
That's
see it
very
on the fluoro coming deep.
And you want to grind. You want to continue to drill until
these little markers. Can
the
you
anterior.
talk to the viewers about the red, yellow, green? Do we want to hit one of those?
To tell you the truth, you want to remember where you landed. Okay. You want to always rely on the fluoro of visual feedback in regards to depth, because all SI joints are different.
Okay.
So you want to rely more. This is more and more as a remember.
Yeah, so wherever we stop on our drill, we have the same markings on our
Got
inserter,
it.
so we
That's
know
what
the depth is going to be the same.
You don't make a mark on an instrument that's colorful like that
Correct.
if you don't want the doctor to notice it.
Yeah.
Not very
That's right
true.
past it looks like a sticky note on our forehead. But it's there for a reason.
So when you're pulling out, basically you keep the same motion, you keep drilling clockwise, but at this time, you're taking it out. So this would have been bone marrow. So very important. You get the best bone marrow from the iliac crest. So it's
Five trust is the real deal, baby.
So this is
That's
so here basically this is the one the picture. You want to save this. You want to save this view here to make sure that to show and have in record that we didn't go anterior, that we
deep.
go
So
too
that-
deep. So that shows us
sitting
the
at the
top.
bottom of the well
At the
that you
bottom.
drill.
Exactly, correctly. So now that's it. Since we've taken this shot and we go like this to make sure that it doesn't power through or anything like that,
Perfect.
we know that it's perfectly safe to go ahead and do the implant.
Your rep has loaded it.
Yep.
There you go.
Loaded the weapon for you.
My man, that's why we keep them, right?
That's right.
So if this wouldn't have been bone marrow, we tap it around. That way we eventually will fuse and have a nice fusion at the level of the joint, which that's the idea of everything. So this comes to the part of remembering the level of the collar that we previously drilled. So
We
because
were like that guy right there.
that guy right there, the third one from the top down.
I don't catch much, but I can pay attention to one thing at a time.
That's all you need. Do one thing well.
One thing good.
That's what I tell people all the time. Do one thing well.
You got there
One thing well, yeah. All right, so it's like here, that's not going over, but in
Maybe a bigger mouth.
just muscle, just
Second green
muscle.
line. He wants to do the first green line.
There you go. So you don't in the deployer. You want that deployer again to be to the level of the crest of the bone.
Yep.
That way we deploy the device, and deploying the device in this case is just doing this clockwise to deploy no counterclockwise. Sorry, and then make sure that this one. When this happens, and it keeps happening, we have this option.
presentations.
Yeah.
What do you do now?
No, but actually, exactly.
Yeah,
It's actually reality.
Really good.
It's really good because if this happens for some reason, some malfunction, too tight, whatever, literally your assistant will pop it out, and then you use their backup.
Is there any reason behind the graft? The shape of the graft, the length of the graft, is there or what?
Yes,
bones-
basically
what the graft is made of?
the drill is smaller than the actual graft.
Okay.
So when you hammer this in, it's pressurized.
Okay.
That way it doesn't pop out.
Okay.
So this will be another way of putting it in. You would take the bone marrow, put it in there, and now you're using this device instead of
cam.
deploying it.
Okay.
Right.
Bone tap.
Yeah.
Yep, absolutely.
Yep.
Absolutely.
The implant's a Concellus allograft.
Concellus.
That's what we're using.
Now obviously this is not going to stay like prior. If you had the prior, don't be too proud that you did things fast, because sometimes you pull everything out, all of a sudden you still have to do the whole thing again. So you don't want to do that.
But
So first,
these companies have those backups too.
Yep.
yes,
That's,
yes.
that's always the question
Yes.
that a lot of people have for me. It's like, all right, I get it when it goes perfect.
Yep.
Anyone
Right.
can do it when it goes perfect.
When's that
And
gonna
that's
happen?
perfect how easy that is just to put the tamp in
Just
and nail
pull-
it down.
Exactly, because that sometimes you have a surgical tech that is new or doesn't know the device or whatever. Things like that happen all the time, and
patient's still going to get a great outcome here.
absolutely.
That's
So
Can you
typically,
see it on the fluoro? Can you
no,
see the graft?
no. Well, if we would have had enough bone marrow in there, yes,
Okay.
you could have seen it. If you
Can you
want
see a
to,
little bit of
if you wanted to document a little bit better, or in regards to
That's what I was wondering
fluoro
about.
wise, you can dip it in ISOView as
Okay.
well.
Okay.
Yeah.
But itself is radiolucent. Yes.
Very cool. That's the procedure.
That's the procedure.
Close
Typically,
them up and
patients do very well. Especially if what I call a hole-in-one. A hole-in-one to me is when I get this guide wire
Yep.
and I make it on the first try to the joint.
Yep.
Because sometimes, obviously, some joints are different, especially if you already fuse one side. When you already fuse one side, the other side tends to be a little bit
a little tighter.
tighter, which I recommend. The other day I had a patient as soon as last week that typically she was only complaining on right-sided pain. I did the right side, she did marvelous. And then I explained to her in regards to what we're doing or trying to do in regards to the motion of how if you fuse one side, how the other one becomes more hypermobile. And then she said, Doc, you know what? I trust you. Let's do this. I did the other one. Guess what? Now she's even better.
That's great.
Like her brain was zeroing in on what hurts the most, and she didn't even notice that she was also hurting a lot on the left side. So when I finished that left side, she did marvelous.
Well, I think this is great. Do you have any questions from the audience, from the VR or for the Zoom? I think we're good.
All right. So we're at SI-Fix.com.
We have one question from someone on the VR. Go ahead.
Hey, Dr. Sanchez, quick question. So you may have touched on this when you're talking about patient selection, but how many SI joint injections will you do before you actually move on to this? And how long will it lead?
Typically 2. And we're mostly looking for what I call a significant amount of relief for a significant amount of time. Every patient differs in regards to how swollen, how mobile, hypermobile that joint is. So I always go by the premise that if I numb a structure that is the pain generator, I will get some type of relief, even if it's a week or 2, or even if it's 6 months. So the time frame, I don't really say if it doesn't last 3 weeks, it's a negative test. So I mostly go with that conversation with the patient if it's worth moving forward. That's why under live X-ray, under fluoro, is a little bit more accurate to be able to move forward to the fusion, because as I said at first, sometimes I just do it bedside just using anatomical landmarks.
And how can the docs out there, the patients out there get more information?
Yeah, you can visit the website, si-fix.com, or email info@si-fix.com. So
Perfect,
thank
guys.
you, Dr. Stevens, Dr.
Thanks, man.
Saprito.